Picture based questions. Today I will be taking more of RPD and mainly the image based questions along with the in the RPD section or in the cast partial denture section, right? So first image, if you are able to see this, first of all, see there is a image. You can see that there is a bilateral edentulous area, posterior bilateral edentulous area, and there is one more space that is present anteriorly that is crossing the midline. Now most of the students they make a mistake in such a in such cases where we have this and they say in another option they will be Kennedy's class 4 mod 2. So mind you, the most posterior edentulous space decides the classification, right? Okay, so in this it will be Kennedy's class 1 and mod 1, and not, it should not be called as Kennedy's class 4 mod 2. No, it is a wrong thing. Same thing, if you can see on your right, you see a partially edentulous situation. Again, it is Kennedy's class 3, and you count out the number of edentulous spaces more apart from the primary classification. So according to the Applegate rules, most posterior edentulous space decides the classification. Apart from that, they will be called as modification areas or modification spaces. So we see there are two more modification spaces. So it will be Kennedy's class 3 mod 2. I hope it is clear. I hope it is clear. Next, just observe the major connectors and that's it, so that you have a picture memory. So the first major connector that you are seeing, it is an anterior posterior palatal bar. Second thing you are seeing, you are not seeing any, so anterior posterior palatal bar. Second thing is a U-shaped or open horseshoe shaped maxillary major connector. Open horseshoe shaped maxillary major connector. And third, you are seeing the anterior posterior strap or the closed horseshoe shaped maxillary major connector. Closed horseshoe shaped maxillary major connector, right? So just I will tell you some important points. The anterior posterior palatal bar, remember this, whenever you are giving a bar, you are covering less of soft tissues, so the abutment support has to be the excellent. The periodontal support of the abutment has to be excellent. Open horseshoe shape to accommodate the tori, a big tori starting from the hard palate till the posterior part of the till the starting of hard and soft palate. But the problem here is, and it is also indicated when you are replacing only the anteriors. It is contraindicated when you are replacing the posteriors. Why? Because most of the times the question comes is that it will flex laterally, and that is a contraindication for any major connector. And one more important point that comes in open horseshoe shaped maxillary major connector is that it derives its indirect retention from rugae. Remember, rugae is not a very good area for indirect retention. Why? Because for indirect retention you require hard tissues, for example a flat surface of the teeth, but the soft tissues are not considered to be one of the very good options for indirect retainer positioning. So but in this horseshoe shaped maxillary major connector, we see that there is it is contraindicated in distal extension. If somebody asks you which is the most versatile maxillary major connector, it is anterior posterior strap or double strap, right? So it is one of the most structurally more rigid and the most versatile maxillary major connector that can be used in almost each and every situation, right? Then you see it's a complete palate, mainly the complete palate or the complete palatal maxillary major connector. It is indicated in when there is a the cleft in the palate, or where you require where maximum number of teeth are missing and you require maximum indirect retention, maximum support. Okay, there you give complete palate. Also you require complete palate when there is a parafunction, when there is natural opposing teeth, when the masticated dynamics is required. Okay, so in such cases you can give your complete palate major connector, but the major indication is a cleft in the palate, and so as to stop the oroentral communication Okay. Third, just see the pictures, that's it. So you can see a lingual bar in this picture, you can see a lingual bar this picture. Why? Because it is the most versatile mandibular major connector, where it can be given in tooth supported cast partial dentures, and you require at least 8 mm space, 3 mm from the gingival margin and 5 mm, 4 to 5 mm should be the width of the lingual bar. In this picture, this lingual bar is converted to lingual plate. This picture I am talking about. So lingual plate, maximum questions are being asked, its modifications and the lingual plate. Write down, it is mainly given in distal extensions where the ridges have undergone vertical resorption. Remember this. Okay, you can see a plate. So, and it is the round portion is towards the soft tissues and the tapering portion is towards the cingulum of the teeth. And you can see one thing, each and every major connector, mandibular major connector, is supported at each end. It is very, very important. The lingual plate as well as any modification of lingual plate, at each end it has to be supported by rest. Remember this always, otherwise it will be totally ineffective. So it is given when you require splinting of the teeth in periodontally compromised dentition, in distal extension cases. Also it gives the option of replacement of future teeth if one of the teeth is grade 2 mobile, something like that. Okay, if you see that the teeth are lingually inclined and you cannot give the major connector, so we have a labial bar. You can see the third picture, it is a labial bar. Just have a picture of it. Now in this is a modification of lingual plate. You see that it is a double lingual bar or Kennedy's bar. It is given when the periodontal condition has left some interproximal gaps, but the teeth are at contact point. So you just, so that the metal should not be shown from the labial aspect, so you make it a hollow and you see two bars running. One is a lingual bar and upper bar, it runs just at the cingulum of the teeth. So it is specifically given, it provides indirect retention where the periodontal condition has left interproximal spaces. Again, in distal extension cases you can give. And one more scientist came which removed the lingual bar from this, and it was known as the cingulum bar. Again, the modification of the double Kennedy's bar or double lingual bar or continuous clasp. It is also known as continuous clasp, this one. So I hope it is clear. I hope, see, the pictures are important, right? Anything can be asked. I've shown you, this is the labial bar. Okay, when there are lingual undercuts, very lingually inclined, the anteriors, and whenever there is a large inoperable tori. Remember this, in large inoperable, if it is given that the patient doesn't want to go for inoperable tori, then you can give a lingual plate in such a case by relieving the tori. But ideally the tori should be removed. Okay, clear? In lingual plate, it is given in shallow palate, lingual plate, shallow palate, or it is given that there is a high frenal attachment, so lingual plate is the best answer in such cases. Then you see what is the picture that is given. This is marked, so you can see the proximal aspect and the lingual aspect. So these are the guide planes, and it comes under the mouth preparation stage. So maximum time this question is being asked, what is the order of preparing guide planes and rest? So remember this, first guide planes are made and then the lingual or the rests are made. Why? Because we do not want any alteration in the dimension of the rest seats. So first we decide the path of insertion by keeping the areas flat, and so that they have a single path of insertion. So what is the main advantage of guide plane? Remember this, that it gives the single path of insertion for the RPD. Second, so that the RPD can be removed and put in the mouth without causing any undesirable forces on the teeth or the soft tissues. And the most important question that comes for guide planes is that write down in golden letters, it ensures predictable clasp retention. How? It ensures predictable clasp retention. Raftar Singh, namaste. Thank you so much. So I feel proud of my students. I hope you do wonders in your coming year. I hope all of you get your dream branches and make your parents and teachers proud and dams proud. Okay. So I'm there with you. So kindly, do not leave any stone unturned. Work hard and the luck will be yours, right? Okay. So guide plane also provides passive retention and mainly for the path of insertion. Okay. Remember this, that एक और चीज, one more thing I will tell you is that whenever you are providing a guide plane, okay, so in distal extension cases the dimension of the guide planes as with the rest seats can be slightly reduced as compared to class 3 cases. Again I am repeating, can the dimensions of guide planes and the rest seats be reduced in distal extension? Yes, it can be slightly reduced as compared to teeth supported. Why? Because there are a lot of rotational forces in distal extension cases, so there might be orthodontic tooth movement, because if the rest seats are very deep or if the guide planes are too much in dimension, so it might cause undue leverage forces on the abutment. Okay, clear? I'm just touching each and every topic with the help of now what is this clasp. Okay, so if you see that it is a simple circlet clasp, you see there's a edentulous area and the clasp is the clasp is taking support of the undercut that is in the far zone, that is away from the edentulous area. So this is a simple circlet clasp. Remember this, the simple circlet clasp is mainly indicated in Kennedy's class 3. Okay, it takes the it goes into the undercut that is away from the edentulous area, that is known as the far zone. So it is simple circlet indicated in Kennedy's class 3. एक और क्वेश्चन आता है बेटा कि Kennedy's class 3 में रेस्ट सीट कहाँ दी जाती है? Remember this, in the Kennedy's class 3. Why? Because the clasp will be engaging the undercut in the far zone, so the rest seat and the rest will be coming adjacent to the edentulous area. Very important question. So the rest seats will be given adjacent to the edentulous area, but the clasp will engage the undercut away from the edentulous area, that is far zone. Okay, right. Okay, what is the clasp? This is modified crib clasp or the embrasure clasp. Okay, एक बिच्छू की तरह लग रहा है, स्कॉर्पियो की तरह. So you see that it is mainly indicated, it is mainly indicated where where there is a, for example, if on one side there is Kennedy's class 2 and on other side there is no modification space, you see that there is a complete total dental component without any modification areas, तो वहाँ पे हम modified crib या embrasure class दे देते हैं, right? So the clasp here is embrasure clasp. It is difficult to fabricate, difficult to adjust, it might break or distort. Okay, you have to create more space on the labial aspect, between two teeth and the lingual aspect, है ना? So you have to be careful while giving these clasps, embrasure or modified crib clasp. You see it's a reverse circlet clasp. If you see that reverse circlet, it engages, it is, if this is the edentulous area, so it engages the undercut in the near zone or near the edentulous area, so it is reverse circlet clasp. It is mainly indicated in cases of distal extension cases. Remember that in distal extension cases mainly there are three clasps. Best is the I bar if it is still premolar, or it is the reverse circlet clasp. Remember this, that you do not give simple circlet and reverse circlet clasp. Why? Because there are undue leverage forces, tipping forces on the abutment. Okay, got it? Got it? Any doubts till now? I am seeing the section. Okay, Now the reverse circulate clasp, there is one problem. Why? Because it is coming from the mesial to distal, so it is less aesthetic. Plus you require a lot of occlusal clearance from the opposing teeth. Remember this, you require a lot of occlusal clearance. It is not aesthetic. Other clasp that can be given is your bar clasp, and also the hairpin or the C clasp or the reverse action clasp in distal extension cases. So with all practical purposes, we can say that the clasp that in the distal extension cases you are engaging the distobuccal undercut. तो distobuccal undercut को कौन engage करता है? Bar clasp, the reverse circlet and the hairpin clasps. Okay. What is it clasp? This is a multiple circlet clasp. So those simple circlet clasps are joined at terminal aspect of the reciprocal elements. Okay. So this you see from the label aspect, and from the other aspect you can see that. Okay, so you can see that it appears that they are splinting these two teeth. So when you are, the periodontal condition of the teeth is compromised, so this will cause splinting effect and will distribute the forces among multiple abutments, right? So you have to see that where the periodontal condition is compromised, you can give multiple circlet clasp. They tend to splint the teeth. Okay, clear? Okay. What is this clasp? This is a hairpin clasp. From the point of origin, it is reversing back to the and taking support of the distobuccal undercut. So it is what clasp? Hairpin clasp or C clasp or reverse action clasp. Okay, hairpin, C or reverse action, again indicated in distal extension cases. But remember this, that for this you require a good occlusocervical dimension of the teeth. You require excellent clinical crown height. Okay, got it? What is this clasp? This clasp is a ring clasp. This is a ring clasp. Why? Because you are engaging, because of the tilted teeth, you are going on the lingual aspect and engaging the undercut on the same side. And also one more thing that is important, because its length is too much, so we give a supporting strut on the labial aspect. So if somebody asks you supporting strut is given in which kind of clasp, so we give on the ring clasp. So what is the indication of ring clasp? We see that there are tilted molars. And the rest seat that is given, it is an extended rest seat. So it's a ring clasp. Okay, again very flexible, length is more, retention is lesser, so you have to be careful. Okay, so in tilted molars we can give a ring clasp. Okay, this is another class that is normally you people don't study. This is half and half clasp. Write down half and half clasp. From one side it acts like a couple, couple, as we trying to in orthodontics we try to combat rotation of the teeth. Here also, if the teeth are rotated, we give half and half clasp. Kindly see to it. Normally it is not, people don't read about it. Just see that ek side se, from lingual side it is there and from buccal side, so you see that it is a half and half clasp. It is indicated in isolated rotated teeth. Rotation is there, half and half clasp. Okay, which concept it is there? This concept is a RPI concept. RPI concept is based upon the mesial rest, the distal proximal plate and I bar. So it's a RPI concept. It is based upon the minimum tooth and tissue coverage with maximum stress optimization. The fundamental that it is based, I am repeating, it is based upon minimum tissue coverage, there is soft tissue and hard tissue coverage, and maximum stress optimization. So there is mesial rest, distal proximal plate and bar clasp. RPI concept. There is also RPA. If mesial rest is there, distal proximal plate and in spite of bar clasp, there is a there is a circumferential clasp, then it is a RPA concept, right? Okay, now what is marked here? If you see that the area that is marked, it is the area of indirect retention. Remember, is that where you require indirect retention? You require indirect retention in cases of Kennedy's in distal extension cases, Kennedy's class 1, Kennedy's class 2, and in long span Kennedy's class 4. You do not require indirect retention in Kennedy's class 3. So in such a case, it is Kennedy's class 2 mod 1. So what you do is you draw a fulcrum line from the most terminal rest on both the sides and take a perpendicular bisector, and wherever it falls, that is the ideal location of the indirect retainer. So how can you say that your indirect retainer is effective? So more the distance from the fulcrum line to the indirect retainer, you see that there is it will be more effective. The minor connector carrying the indirect retainer, it has to be rigid. The rest has to be functioning excellently well in the rest seat. Then only the indirect retainer will be more effective. Okay, got it? And the indirect retainer will basically prevent the heel effect. Also, it will prevent the the rotation in a distal extension case by shifting the fulcrum more anteriorly as possible, or more farther anteriorly as possible, right? So it can be in form of occlusal rest, it can be in the form of cingulum rest, or it can be in the form of incisal rest. There is something known as lug seat. So from the premolar, if there is an extension on the canine, so for example this one, if you see, there will be an extension on the canine in continuation with the occlusal rest, which will be called as lug seat, LUGSEAT. So indirect retention is required. And remember is that if the question comes that Kennedy's class 1 is an example of, of class 1 lever. If somebody asks that the Kennedy's class 1 with a indirect retainer is an example of, then it is changed to lever 2. That is mechanically more advantageous. Lever 1, the fulcrum will be in between. Class 2 lever, load will be in between and effort will be in between in Kennedy's class in lever 3, right? Class 3 lever. Okay, so always remember that the class 1 lever is always deleterious. Always try to change your class 1 to class 2. So if we want the load to come in between, so what we do is we shift the we add indirect retainer as far anteriorly farther possible, so as to convert the fulcrum line to anterior portion, right? So indirect retention is mainly given in cases of distal extension cases or into tissue supported RPDs. Okay, one more thing you are able to appreciate in distal extension case, this one you can see it's a tissue rest. Remember this, it is a tissue rest, or it's a tissue stop, tissue stop, mainly given in distal extension cases. Why? Because so as to provide avoid distortion during casting. So this is a tissue stop in the framework of the distal extension cases. So when we be packing, this tissue stop will be contacting the ridge, and while packing we see that the acrylic goes from the top and also goes from the within, so there are chances of distortion. So to avoid distortion, we gave a tissue stop. Many times this had been asked. Remember that tissue stop, this is not the same as a tissue stop that is given in your trays. In complete denture trays, tissue stop is given to for proper orientation of the tray. Okay, but in framework, tissue stop is given to prevent distortion during the processing of the cast partial dentures. Okay, now what this is, which blockout? Mind you, there are 3 types of blockout. This blockout is a ledge blockout or a shaped blockout, which will determine the clasp position. Right down, it will determine the clasp position. Okay, so this is a shaped or ledge blockout, okay, or tapered blockout. You can see that. Okay, so this is a shaped blockout, the green one, where you just arbitrary blocks it. Why? Because this is not involved in the design, so this is known as arbitrary. The green will be called as arbitrary, the red will be called as shaped or ledge blockout. Okay, so when you are blocking out the undercuts in the path of insertion below the guide planes in the interproximal areas, so this is a parallel blockout. This is a parallel blockout. Okay, so there are three type of blockout: parallel blockout, second thing is the shaped blockout, and third is the arbitrary blockout. So whenever you are blocking the undesirable undercuts in the path of insertion, let it be your interproximal areas, let it be your deep interproximal areas, let it be the rigid portions coming in contact with the teeth and tissues. Okay, so and also below the guide planes, so these are known as, this will help in deciding the path of insertion, and this is to parallel to the path of insertion. These are blocked out parallel to the path of insertion, तो उनको parallel blockout बोलते हैं, parallel blockout. Now, two types of finish line are there in the cast partial denture. If you see that this is carved, remember this one. So if I explain regarding the finish line in RPD, there are two finish line. So there will be one finish line. Finish line का मतलब है the junction of the metal with the acrylic. So there will be two junction. One, so when the acrylic flows, one it will flow from the top and one it will flow from the bottom. So remember this, from the top, this is actually carved by the technician, and it is always at an acute angle. Remember this, I need on the external finish line is always at an acute angle, so that there is the acrylic goes and gets mechanically and interlocked in the external finish line, that is acute angle. From below it is always at right angle or butt joint. Internal finish line butt joint on 90 degrees, external finish line is always at an acute angle. So if I show you, so the internal finish line, one more question, the external finish line, you actually carve that as a technician. Internal finish line is formed by the relief on the edentulous area, relief wax on the edentulous area before duplication. Remember this, very very important. This comes one or two times in AIMS. And okay, so the internal finish line is formed by the relief that you give on the ridges, so that you get acrylic below the framework. Okay, just see if you see that this one, so this is the metal framework. On the top it is acute, and on the below bottom it will be 90 degrees, right? So you can see that a butt joint should be used. This is the below one, so it is at 90 degrees. Okay, external finish line should be less than 90 degrees, but internal finish line should be at a 90 degrees or butt joint. Configurations in RPD. So we see that in Kennedy's class 3 mod 3, you can see there is a quadrilateral configuration. We see 4 clasps, beautiful, excellent stability. So 1 2 3 4 quadrilateral in Kennedy's class 3 mod 1. Tripod, maximum question is asked on this tripod or triangular class configuration that is given in, that is shown in Kennedy's class 2 mod 1. Kennedy's class 2 mod 1, in normally in Kennedy's class 2 arches. In Kennedy's class 1 you see bilateral configuration in Kennedy's class 1, and you add one indirect retainer on either side of the middle line in Kennedy's class 1. Okay, one more thing I'll just teach you. Okay, just the designing portion, just have a look if this is the designing portion. Okay, so in Kennedy's class 3 you see that we give a lingual bar for example. Okay, you see that the four clasps are added, and you see the mesial rest on the adjacent to the teeth, right? There will not be any rotational forces. Okay, right? So that is why you have not added any indirect retainer anteriorly, right? In, for example, in Kennedy's class 2 mod 1, you see that perpendicular bisector is forming on this premolar tripod configuration. Okay, uh, so let me also tell you regarding the steps of the cast partial denture, the laboratory steps. As the patient comes to you, you first make an impression, pour the diagnostic cast. After pouring the diagnostic cast, the first step is the surveying. You do it on a surveyor or a parallelometer. It was given by AJ Fortunati. There are two types of parallelometer, that is your the knees, that is the earlier one, and the Wills, that is the newer one. In the knees parallelometer, you see that the horizontal and the vertical arm are fixed. In Wills, the vertical arm is movable or spring loaded. It is a much more advanced version. So remember this, that first thing that is important is the you decide everything, and you by doing surveying of the diagnostic cast. Once you have done that, then you do the mouth preparation in the patient's mouth. There are the rest. Remember this, that there are three types of rest seats. One is the occlusal rest seat, second is the lingual rest seat, third is the incisal rest seat. The occlusal rest seat that you prepare, then you prepare the guide planes. Remember, सबसे पहले guide planes prepare होंगे, then the rest seats. Okay, the rest seats, remember that the occlusal rest seats, it is roughly triangular in shape. The base of the triangle is towards the marginal ridge. Always remember that whenever you are going for preparation of occlusal rest, the marginal ridge has to be reduced by 1.5 to 2 mm. Always major question comes, why? Because the occlusal rest have got a horizontal as well as vertical component. If you don't prepare enough in the marginal ridge area, you will see that the metal at the junction of the two remains lesser, and it might break. The major connector and the rest, if it is broken, then it is never repaired. Remember, then you have to go for a new cast partial denture. The major requirement for any major connector is rigidity. If it is not rigid, it will lead to you know uh, it will lead to stress concentration at the level of teeth or at the level of the dentulous ridge. So it should never be flexible, right? Then once you have done the diagnostic cast, surveying, then the mouth preparation, then also you do tripoding in this time. In the NEET exam, tripoding question was asked. So what you do, the tripoding, you just take three, you mark three widely spaced points on the cast, or also you see that the surveying rod is, you mark something on the base of the cast and then you, at the same angulation, when it touches in the master cast, you can just see the angulation is same for both the diagnostic cast and the master cast, so that there is no problem in designing of the cast partial denture. Then you do master cast surveying. After master cast surveying, if you see everything is perfect, there is no problem, then you do the relief and the blockout in the master cast. After doing relief and the blockout in the master cast, then you go for duplication in the refractory material, then you get a refractory cast. After refractory cast, you can dip it in the beeswax so that the wax pattern will stick to it. and then you go for the wax pattern fabrication on the refractory cast. Then you do spruing. Okay, the spruing के बाद investing के बाद burnout के बाद the casting with the help, if you are doing a casting of cobalt chromium, or you can do milling with the help of titanium. Okay, and then you go ahead with the casting. After that you go with the finishing of the framework, seating the framework on the cast as you are seeing in the picture. Okay, then you seat the framework in the patient's mouth. After doing that, if everything is fine, then what you do is you do the jaw relation, then you do trial, then do every processing step that is given in the book, right? So we have to go for all these procedures, finishing and polishing in the last step. The occlusion should be perfect. Mind you that whenever any complete denture is opposed by any RPD, you give a balanced occlusion. Any soft tissue supported RPD, for example Kennedy's class 1 or Kennedy's class 2, supported by same, so you require balanced occlusion. Kennedy's class 3 against natural dentation, you do not require any balanced occlusion, you just need centric and the working contacts, don't require any protrusive or eccentric contacts. Kennedy's class 2 opposed by natural dentation, there is an important question that Kennedy's class 2 mod 1 opposed by natural dentation, what occlusion would you give? So the answer there is group function or canine guided, depending upon the teeth missing or the teeth present, right? So you can go ahead with that, right? Class 4 against class 4 or class 4 against natural dentation is that you in centric the lower teeth can contact the artificial teeth, but in eccentric position it should not, right? Okay, other questions, very very important questions, is that what are the material with which mainly this cast partial is made? It is cobalt chromium, they are base alloys, and that they are rigid even in thinner cross sections. This is a very very important question. Even the thinner areas try to, for example the maxillary major connector or the mandibular major connector, they should end in the rugae के बीच में there are crests, in the valleys in the crest, they should end in the valleys in the crest and never on the crest. Always try to, they should be as inconspicuous as possible. The clasp should be placed in the gingival third and it should always point vertically, always point incisally. The most important question mainly comes on combination clasp. The combination clasp is a clasp that has wrought wire retentive terminal, and reciprocal clasp should be rigid cobalt chromium. It is mainly given where you have to engage, write down, combination clasp is mainly given where you have to engage mesiobuccal undercut in distal extension cases. Normally we engage the mesiobuccal undercut with the help of reverse circlet, but somehow if it is not given, okay, so if indirect tension, one more important point is that what is the, if you see the difference between the circumferential and the bar class, there are excellent differences. So if we talk about the difference between these two, the circumferential clasp, the circumferential clasp is also called as Ecker's clasp, or the occlusally approaching clasp. The bar clasp is also called as the Roach clasp, or the vertical projection, or the gingivally approaching clasp. They are more aesthetic. The bar clasp are more aesthetic. Circumferential clasp, they have the encirclement of more than 180 degrees, a continuous encirclement it is there. In bar clasp, it's a broken type contact. Remember this. Okay. The very important point that I wish to make is that in the circumferential clasp there is a lot of decalcification. Okay, it is based upon circumferential clasp based on pull type retention. The bar clasp based upon the push type retention, push type. Okay, it will, it will take more food debris. The bar clasp will take more food debris. It is easier to, the bar clasp is easier to insert, difficult to remove. The circumferential clasp is ulta. It is difficult to insert but easier to remove, right? Bar clasp are more aesthetic, but one of the major disadvantages of bar clasp is that you cannot use this in case of soft tissue undercuts labial to the teeth. Remember this, the major contraindication. Okay, then you see one more thing is that minor connectors. Okay, remember this says that only minor connector that is flexible is the I bar of the approach arm of the bar clasp, this one. Otherwise these are the minor connector. Whatever minor connector are the missing are the connecting link between the major connector and the any other portion of the cast partial denture. If you see, the major connector is this, the rest is this, so missing is the, so between these two it is a minor connector. This kind of minor connector you tend to make it as inconspicuous as possible. You tend to place it in the interproximal embrasures and not in the facial aspect of the teeth or on the center of the teeth. Okay, these are guide planes, these ones, guide plates. Okay, provides passive retention, also helps in the path of insertion. So now we will talk about the minor connector. If you see that these are the minor connector that helps in engaging the teeth with the major connector. Okay, so if we see that in the distal extension case, it is what type? It is loop and ladder design, that is extending till the two-thirds of the retromolar pad in the mandibular ridge and complete maxillary ridge in maxilla. Okay, it is mainly indicated in Kennedy's class 1 case or Kennedy's class 2 cases. There are other types also. The major question that comes is in these is that we can reline it. It provides the strongest attachment with the acrylic. Then there is mesh type, that is mediocre, but we require a lot of force while forcing the acrylic into these holes. And the last is the nail or the bead head type or the solid pattern type, where the attachment is the weakest. Remember that the attachment is weakest. It is solid metal. There you have given nail, bead wire, nail head. Okay, so the attachment is weak and you cannot reline that. Remember this. There in this strongest attachment and you can reline it. Okay. Then one more important point is the distal extension cases. You tend to make functional impressions. For example, Hindle's, McLean's, functional reline technique. Okay, but in case of other technique is that you make impression. In Kennedy's class 3 you just require single impression, anatomic impression, but in case of Kennedy's class 1 and in case of distal extension cases, you just have to make functional impression. You have to record the ridge in the displaced form so that you reduce the difference of resiliency between the teeth and the ridge mucosa. Okay, got it? So another technique is the selective pressure technique. One more important point is the altered cast or the corrective cast technique. Altered cast technique or the corrective cast technique, again it is mainly done in case of distal extension cases to relate the anatomic portion with the functional portion. Okay, so this is it. One more thing. some questions relating the, if you can see this, if you see the lingual bar, you see that it is half pear shaped in cross section, half pear shaped in cross section. The round portion is in the floor of the mouth. Tapered portion is in the is pointing upwards. One more important thing is that in lingual bar, if the teeth is mobile, for example, you cannot replace it back in the framework because it is away from the teeth as compared to lingual plate, where you have the provision of replacing the teeth even if it is predominantly compromised right now. So okay, so you have to be careful, right? One more important thing is that last but not the least is the fulcrums. The fulcrums, if you see that there are three fulcrums, question comes, three fulcrum lines in Kennedy's class 1. So it is the most difficult RPD. Three fulcrum lines. First fulcrum line is the horizontal fulcrum line. So in the horizontal fulcrum line, it is passing from the terminal rest in a horizontal way, but the movement is in anterior posterior direction, that is sagittal direction. The magnitude of forces may be more, but they are less deleterious, less harmful. Second fulcrum is in sagittal plane from the distal, if you see that from the distal rest to the center of the crest of the ridge, but the movement is in vertical direction. The rocking movements, again the forces are lesser, but they are highly deleterious. Third fulcrum line is in the just behind the central incisor in the midline. Okay, the fulcrum is in the vertical plane, but the rotation is in horizontal, horizontal rotational movement, very difficult to control. So remember, in distal extension cases, especially in Kennedy's class 1, there are three fulcrum that is informed, three fulcrum lines. Last but not the least, if somebody asks you the example of livers, so class 1 liver, we know that Kennedy's class 1 with the indirect retention, without indirect retention becomes the class 1 liver, with indirect retention becomes a class 2 liver where the load is in between. Also the maxillary RPD working under sticky food, maxillary RPD working under sticky food or under the gravity is an example of class 2 liver. Many times question has come, class 3 liver, example Kennedy's class 3 RPD with sticky food. Remember, Kennedy's class 3 with sticky food is an example of class 3 liver. Another points that comes into my mind in RPD, remember, is that the occlusal rest, it is made with the help of number 6 or number 8 round burr. The floor should have smooth inclined curves. It is having more depth in the center. The floor is having it is saucer shaped or spoon shaped. Okay, got it? And it provides vertical support. When providing the vertical support, the forces are going cent% in the center of the teeth, 100%. It provides vertical support and it prevents the impingement of the framework in the soft tissue. So it prevents this movement, vertical movement towards the tissues. That's why it is called as it provides vertical support. It provides vertical support. Okay, it is one of the best rest seats that we give, roughly triangular in cross section. Okay, the second is the lingual or the cingulum rest seat, that is mainly indicated in case of maxillary canines. Why? Because maxillary canines, why? Because it is a facial lingually a broader teeth. Okay, and and the incisal rest is mainly given on the disto-incisal rest of the mandibular canine. Okay, avoid incisal rest as indirect retiners. Okay, if possible, always go ahead. The order is as indirect retiners, an occlusal rest followed by cingulum rest followed by incisal rest. If you have to choose between the cingulum rest and the incisal rest as an auxiliary rest seat, remember is that the cingulum rest will always have an excellent biomechanical advantage over the incisal rest. Why? Because if you are having the same teeth, right, you see that the distance between the rest and the center of rotation in case of cingulum is lesser as compared to incisal, because incisor ऊपर होता है, right? So the distance is more, so the chances of off axial direction of force may be more. So it is always better that if you go ahead with the cingulum rest as compared to incisal rest. Another question, the most important property of RPD, remember this, is retention. If somebody asks you the most important property of RPD relating to the health of the oral tissues, it is always support. Okay, health of the oral tissues that prevent impingement is support. If it is normal, most important property of RPD, retention. Minimum number of clasps required to design a RPD, it is 2, because you require the best example or the best advantage of RPD or a cast partial denture is cross arch stabilization. The forces from one side of the arch is being counteracted by the components on the other side of the arch. Okay, so this is the major advantage of RPD. So in the first session I tried to take in my previous class I tried to take the concepts, important concepts and the figures of FPD. Today I have taken mainly the RPD part, and I wish you all the best. Happy New Year to all of you. And I am wishing each one of you, who have worked so hard, that kindly, keeps your head high, keep working hard, and the success will be yours. Thank you so much. All the best. Shabba khair. Good night. And the success will be yours. Thank you.
हाँ महेंद्र, स्टार्ट कर दिया है मैंने।
सर एक मिनट रुकिएगा बस, मैं यहाँ से अपने यहाँ से लाइव कर दूंगा, तो आपको मैं ना व्हाट्सएप पे मैसेज डाल दूंगा।
ओके ओके डन।
आज भी उनका चेतन पाठक सर चल रहा था अभी।
ओके ओके, जैसे ही लाइव करो ना मेरे को थम्स अप भेज देना।
तो मैं आपको मैसेज कर दूंगा।
ठीक है सर, ओके।